thalamic and mammillary body stimulation a few years ago. That means that the target was there. And when I presented my program to the peer review committee, ethical committee, I said, you know, we have an experience of performing the brain stimulation for Parkinson's disease since at least 18 years. And the target for Parkinson's disease was the STN, subthalamic nucleus. That means a group of neurons which are located below the thalamus. It's very logical. And I wanted to target, as I told you a few years ago, the mammillary bodies and the mammillary thalamic tract, the MTT. And I said, look, the mammillary bodies and the mammillothalamic tract are just inside the STN, so I do not see any problem to target that. And I received the green light to do that, and we performed a few cases. We used this kind of electrodes, and you see our first case with electrode placed into the MD and the MTT without any problem. Unfortunately, one of the patients fell on his head, broke his electrode, and as he was happy with the stimulation, he asked us to perform a second procedure. And so we replaced his electrode, and when we did that, he developed a memory deficit enough to freeze the program. And I'm very sad with that, because I think we were on a very nice track, and we have published a few papers about that you can find in the literature. And this very nice study, Santé, with the target of the enterothalamic nucleus appeared. I knew that there, the target is the anterior thalamic nucleus, which is there. I remember to you that the mammillary body is there, and the mammillary thalamic tract is just here. But what's funny, you will see later that the best way to target the ATN is to target as well the MTT. So the Santé trial was published in 2010. They used a stimulation of 5 volts with a frequency of 145 pps. The length of the stimulation was 90 microseconds, 1 minute on, 5 minutes off. And it's incredible. The results are incredible because we are dealing with patients who are truly refractory. They are refractory for standard epilepsy surgery. There are people at the end of the process, and we cannot cure them with drugs, we cannot cure them with standard epilepsy surgery. And you see that 40% of them, after 4 months of stimulation, have a significant rate of decrease of the rate of seizure, and at 5 years after the beginning of the stimulation, 2/3 of them have a 50% reduction of the seizure rate. And what is incredible more, 19% of them are seizure-free. 1 out of 5 seizure-free. The problem is that for some people we have observed a reduction of the verbal expression. They are a little bit depressed, and in some people you can have an increase of the rate of simple partial seizure, the SP. But the method that you have to remember is this one. With ATN deep brain stimulation, 5 years after the beginning of the program, 1 out of 5 patients will be free of seizure. That's incredible. But now I would like to concentrate on the way to perform this kind of stimulation, and you have, all of you recognize a very nice coronal section of the thalamus, and you know that the dorsal surface of the thalamus is this. This is divided into 3 parts by anatomical structures. One is the thalamic stria. The second one is the location of the thalamostuate vein. And the third one is the choroidal tenia for the insertion of the choroidal plexus. And with these three anatomical structures, you can distinguish the lateral part of the dorsal surface, you can distinguish the median part of the dorsal surface of the thalamus. This median part is connected to the velum interpositum, or transverse fissure, which has as roof the fornix, velum interpositum, and the fornix. And we have to target the anterior thalamic nucleus, which is located there. For me, is the most difficult target in the world of functional surgery compared to the SDN, the GPI, of another one, of the bed nucleus of striatum terminalis in OCD. And you see here that the target is located there on a coronal section. You have here the thalamus-striate vein. You have there the ICV. The ICV is the internal cerebral vein. You have there the choroidal plexus with its own vascularization. And between this structure, you have a few millimeters. And you have to go like this. You have to go through the thalamus-striate vein, between the ICV, between the choroidal plexus, on a very specific target, which is not big, which is named ATM. And to do that, you have to go through the ventricle. Before, in deep brain stimulation, the ventricle was forbidden. No, the target imposed you to go through the ventricle. And so we have developed some way to do that without particular problem. Santé has published that if you want to get the best results in ATN DBS, you have to target the anterior part of the ATN, and the best way to target the anterior part of the ATN is to identify the entity. Look at this project that we have developed more than 10 years ago, and you see that on this very nice coronal section obtained in MRI, we can see here the entity, just above it, the ATN. I will show you that on this one. You see the ATN is there, thalamus-striate vein is there, ICV is there, and the entity is there. And the best results were with electrodes located in the ATN and touching the entity. You see, so to do that, we place our trocar inside the thalamus, and the target, I mean the tip of the trocar, is located between this electrode, the electrode number 3, and the electrode number 2, so that the tip of the stimulation will be located between the last two electrodes of the big electrode. So we performed our first ATN in April 2016. You see here the images. You see the location of the electrode perfectly located in the ATN bilaterally. You see your setup developed in October 2013. I developed that setup especially for spine surgery, but we are using that also for deep brain stimulation and epilepsy surgery. I will show you how. You see a frame. You see the system that we use to perform a check during surgery. And this machine with a robotic 3D fluoroscope, which we use as a CT scan during surgery, has been developed by Siemens. And we are one of the very first to use that in deep brain stimulation. You see that it gives us this kind of CT, pseudo-CT. We fuse the CT with the previous MRI, and we have the confirmation during the procedure that our electrodes are perfectly located on the target. You see the comparison between the Sante program, which is a wonderful thing, with our previous program developed 10 years ago, and that we have stopped because one patient developed memory deficit. Anyway, it's like that. So the result with our first 5 patients, we have actually 9 patients. It's a very new program. It's no mortality, no morbidity, the first thing. Response rate at 6 months, 60% reduction rate. 60% reduction rate, that means these 5 patients who have been operated, who have received all drugs, who have received for a few of them vagal nerve stimulation, we can, with this technique, reduce the rate of seizure of more than 50% in 60% of the patients. That's incredible. However, two of them develop mild memory impairment, but in this case, it doesn't affect anyone because the results reducing seizure is so much better than to have a reduced memory. Then we continue with that program, and we have two cases of transient depression. And to close this presentation, I would like to show you a movie done 1 or 2 weeks ago by Siemens that you can find on the world website of Siemens about our procedure that we developed in my department. So I won't speak anymore. I think you can hear it. Yeah, of course.
Essential tremor. First step, prepare to the nerve. This MRI is performed using a 3.0 Tesla, which will help us to visualize the structure that we are targeting. The second step is the patient goes to the OR, and my colleagues will place on his head a stereotactic frame on which we will place a locator, and the patient with the frame and the locator on his head will go to the CT. Then pushing the patient to the CT to get the CT with the ring and the frame on his head. Then the CT is transferred through the network of the hospital to a computer where I will receive the different sequences of the MRI plus the CT with the frame and the locator. During that time, the patient will go back to the OR while I'm working on the PC to define the X, Y, Z coordinates of the target that I will identify on the MRI fused with the CT. I will send the coordinates to the OR so that my colleagues will be able to perform the first trajectory. During that time, I will go to the OR. I will download the MRI that I will use at the end of the surgery to perform the second trajectory. we need to have a check by X-ray. And we are using the RT0 in a 2D mode. And when all the definitely stimulating electrodes are placed, we will perform an intraoperative quality control. That means that instead of pushing the patient away of the OR to the radiological department, the patient will stay in the OR, and we will use the RT-ZIGO in a 3D mode in a few seconds. I think it's 6 seconds. It's very fast. And the 3D images that we have got like that will be fused on the console, and the fusion of the preparative MRI and the 3D images obtained at the end of the surgical procedure with the patient in the OR, we can check if the two leads, the two different electrodes, are in the place that we have targeted during the surgery. Using the RT-ZIGO has helped us to reduce the time of surgery. I would say it's between 1 hour and 1 hour 30 minutes. So currently we can perform a DBS procedure from the beginning to the end of the IPG location with an average time of 4 hours. Before it was 6 hours, 7 hours. In some departments it will take 1 day. And we have recently published a paper demonstrating that using the methodology that we are using now, can get results as good as all the other people are taking more time. So it's a very nice demonstration that the ZIGO not only help the patient, but help the team and help to be more cost effective.
Okay. Thank you for your attention. It's like that I close my presentation.
Thank you, Dr. Rafapanos. Any questions from the floor?
On the market or the system that you can grip on the skull and which will give you a XYZ trajectory. But some papers has published that the result is not as precise as a frame. And using that, we can go just between the vein. But you have to be very precise and very, I would say, obsessional so that you can reach your target without touching anything else.
How is it different from the OARM and the robotic OARM, CARM, what you have?
Okay, very interesting question. Because I've used all the systems since 10 years. I asked the system in my operating room. At the beginning, as I do also spine surgery, my purpose was to, I was obsessed by the fact that I wanted to perform minimal invasive surgery. When you do minimal invasive surgery, you do not see anymore the vertebra. So I need to see the vertebra virtually. And the best way to have was a system like the OARM there was another system from another company. So they came in the operating room, but the OR is a donut. And to move the donut is very, very difficult. With the ZIGO is a robotic arm that you can use to perform 2D images. So if you want to operate on spine surgery for cervical, you have the OR, you go in the OR, you can perform 2D without being annoyed by the system. With the OR, the donut, you are working against it. One of my colleagues, we are 10 neurosurgeons in my department, 5 of them are 50% in private to make money. I have no problem with that. They are nice people. And one of them just bought a donut. And he told me, Mr. Raftopoulos, it's not the same with the ZIGO, because the ZIGO can go away. You push on a button, the ZIGO is away. The donut stays beside you, and you have to move it. It's not friendly. It works, but it's not friendly. If you can go to a ZIGO, it's better.
Yeah, but what I understand is the principles are same, but OAM with a better mobility is zero.
Yes, the OARM is for me cumbersome. The problem is the arm, especially with, I think OARM is now with Medtronic.
Yeah.
Medtronic is very powerful. Medtronic people will agree with me. And they try to push their arm by decreasing the price. So if I have less money, I would have bought an arm. But I have very nice patients in Brussels, which I have operated on, rich people who have given me to my university money, and I was able to buy the arm, the Zigo. It's a robotic arm for 2D, 3D fluoroscopy. And the 3D fluoroscopy is city-like.
Thank you.
My pleasure. Thank you.
I think you have your next talk as well.
Pardon?
We proceed with the same session. You have the talk on classification of field quality.
It's not. Oh, sorry. I closed my PC. Yes.
Yes. Okay, then
I don't know.
I think. So we have the next talk by Professor Yoko Pato, and she'll be talking on strategies for aneurysm surgery.
So once again, thank you very much. Professor Sepgupta, he is not here, must be very busy in round of the patients. So can you light on, please? So this is in Japan, many of the cases are ruptured, not very seldom to see the rupture case recently. So around 376 cases last 3 years. And location is MCA is the top, and ICPC and ACOM. So today, just I want to, because we have a nice case, just I want to discuss among you. So the giant aneurysm, about giant aneurysm, there are two types. So one is thrombosed aneurysm. It's totally different. It's a non-thrombosed aneurysm. So aneurysm with intramural thrombus. So this is not a non-thrombosed aneurysm. I will show you, because this is just ballooning of the vessel, the MCA. So that we usually occlusion of the aneurysm neck with multi-clip. So this is just ballooning of the aneurysm. So some branch come from the aneurysm dome itself, and once we occlude of the short term of the temporary clip, then so we decrease of the luminal pressure during that time. So that just we can put the first initial clip. Usually I recommend the anesthetic one, because you can avoid the stenosis of the neck area. Then the second clip is just occlude of the fenestration part. So this is one of the key. Anyway, but this is not a thrombus, not partially thrombus. So this is ICG real time, so we can check how much the remaining of the aneurysm neck and the perforators, and also the branch situation. If you need, just you can put the additional one. So the key point of this surgery is just you can understand it's a wide opening of the cerebral fissure. So the working space is very important. So even though the 90% of the occlusion of the neck, almost the aneurysm, the color has been changed, so no more circulation inside because of the thickness of the aneurysm wall itself. So this is the last part of the ICG. And what about the thrombosed, or partial thrombosed of the large type of the aneurysm? Because we focus on the vasovasorum on the aneurysm wall. So this is a big role of the enlargement of the aneurysm. It's totally different from the usual ballooning of the aneurysm, the vessels. So the vasovasorum and the tunica adventitia is the main goal to increase of the aneurysm size. So many things in the written here. So how is the best treatment of the such type of the large aneurysm? So this is a severe compress of the medulla, and the patient we had from the another hospital, the patient gait is getting worse and worse, even the many types of the treatment has been performed in another 2-3 hospitals. So most medulla is just like a papers, and some history of the clots inside of the aneurysm wall. And this is a initial film which I received from the another hospital. The green one is just they put a stent, 2 stent, and also the some this part is the coil part. So, but we cannot see the this is the 3D CT. This is the artery. So, but here is some small faint of the black part of the aneurysm contour here. So this is MRI, and this is the angio. So, but actually we do not see any aneurysm shadow with the 3D, no, the DSA. So this part is a stenting, and this part is coiled. So this is very peculiar. So many times they stent, coil, stent. So this is just before the surgery, and just I want to show after opening the skull. So this is the aneurysm itself. So this is a big difference from the usual ballooning of the aneurysm. The wall itself is very thick, yellow, the scotic change, and this is endoscopic observation, and the lower cranial nerves, and here you can see the very big vasovasorum, which is the nutrition of the aneurysm wall. So, but still, when we put the Doppler, so some sound is listening. But anyways, we trapped of the aneurysm. It's very, very interesting because we wanted to check of the aneurysm wall. So the once we cut inside of the aneurysm, the dome, suddenly the big bleeding. So I think even such image, still the aneurysm is alive. So just we remove some part of the aneurysm wall, such it's including of the vasovasorum and also the remove of the clot inside. And then with cruiser, and this I want to show because very coiling in the aneurysm side. So just you cannot, so how do I say, extract, just you can cut in piecemeal, then otherwise you cannot remove the total coil. So here you can see the stent which they put with endovascular procedure. So we suture where we cut the aneurysm sac and put a clip for reinforcement with glue. So this type of the aneurysm is you cannot cure. You cannot cure with usual sometimes endovascular or sometimes proximal occlusion. So this is pathology, and here is vasovasorum, which we detected here. So this one is vasovasorum. So this is elastic fungism, which particularly we can delineate of the vascular component. So the imaging is onion skin appearance. This is a low intensity of the T1 weighted, and the radiation product of the blood T2 weighted. And also the ring enhancement part is what is that? So that is a dense vasovasorum vascularization. So it looks like abscess. This is what it is this is just vasovasorum. So I want to emphasize is the key role is the vasovasorum and proliferative disease of the vessel wall. not like extension of the luminal pressure. And also, what about endovascular treatment? So, endovascular coiling is not ideal because of the aneurysm growing from the wall side. And the reduced shear stress force is a decreased neural dissection. And also considering when not successful form of apparent vessel sacrifice is palliative treatment. So treatment is not treat vessel wall disease. So and the not treat vessel wall disease, this is a and also when we excite of the aneurysm itself is very harmful. So what we should do? Which one is the best? So maybe the flow diverter is one of the solutions for this type of the aneurysm. But this is a good indication of the flow diverters such as a blister-like or fails the simple coiling. So advantage of the flow diverter is the decreased risk of procedural rupture. So what do you choose? So just observation. This is of course the dangerous, especially dislocating the posterior fossa. And the medication such as steroid, so difficult perforator injury, and clipping not cure regrowth aneurysm. This is just a palliative. And the coiling is a recurrent and also thromboembolic event. And also the status assist coil, the balloon assist coil, this is aneurysm growth. And third, arterial occlusion, plus minus bypass is, so this is, again, this is the aneurysm regrowth. And what about apparent arterial occlusion? This is a thromboembolic event, delayed hemorrhage and rupture sometimes. So the flow diverter is ideal, maybe. So this is what I wanted to say. The partially or summarize of the large type of the aneurysm, you should consider what is the best treatment of the patient. So this is a disease. We should change the name. So vessel wall disease. This is the ideal name, I think. So what is the future target treatment? Therapy is, of course, the vascular flow diverter, but also the role of the anti-inflammatory drugs, anti-angiogenesis strategies. So the next talk is just the DIVA, which I already talked. So the DIVA is just, we can keep the surgical field and plus ICG. So this is just the paracline with small aneurysm. So already the neck is the dura. So I think it's quite useful because this is a usual ICG. Suddenly the blackout, the background. So we can estimate where is the second nerve or where is the skull base or nerves. And sometimes multi-clipping when we use, we should consider how I did the multi-clip applying. So I think only very simple talk, but I think it is one of the revolution, I think. So this is the usual ICG. When we can apply the bypass and also especially the aneurysm very close to the nerves, and also we can apply the microvascular decompression. So this is a trigeminal nerve, and this is a SCA just come from the side. So this is this paper has come from from Japan, and this is also you can apply the deeper part of the aneurysm. This is the vaginal tip. So the left side, just you can see the when we apply the DIVA. DIVA is a dual image video angiography. That means so this is such a deep place. So and also we can check the perforators with ICG, but sometimes it's very difficult because so many perforators. This is a how do I say basement, the work. I think such the liver is quite useful. Just we can evaluate of the parameters. Okay. And also this is so many cranial nerves because this is a pica aneurysm. The pica come from the aneurysm itself. There's so many lower cranial nerves and also the pica and VA in the, so this is just puts a proximal occlusion of the VA. But still some pica come from the from the backbone. So after the bypass, so we sacrifice the pica and also the occlusion of the parent vessels. So it's a very narrow space and also many cranial nerves. And also with all the situation we want to evaluate the aneurysm itself. So this is the liver. So how it's useful for the daily aneurysm surgery. And also the CFD, I talked many times. So we can estimate of the thickness of the wall and before surgery. So the CFD aneurysm growth is related with the high wall shear stress and also the rupture related with the lower wall shear stress. And this is our the result. And also the vector to tell us which part is a static change and which part is very thin, the vector and the streamlines. So this is a ICPC. So this is just we can delineate the images from the behind. So this is a usual ICC and just exact match of our analysis of the CFD. Which part is a little bit static change, yellow part. And this is the NCA, but a small bulging. This part is, we can tell, the very thin part of the aneurysm. Before surgery, we can check. So this is the flow 800 and also ICG. And also the last flow, combined with 40CT, how we can estimate of the thickness of the wall before surgery. That is our goal to obtain the aneurysm, the feature. So this is before rupture and this is after rupture. The shape is, this is ACOM. The shape is a little bit different. This is a rupture point. So this is the surgery through the right general approach. Here is a rupture point. And this is a 40CT. So the 1000 films is reconstructed. So we can obtain this type of the 40CT. So this the big movement. Of course, we can calculate percentage. So this part is the rupture point. So we can tell. So this is you can see this is the thrombus in the ACOM aneurysm top. This is the rupture point. Just is covered with thrombus. So this is our usual endoscope or ICG and Doppler sometimes, and also monitoring is another very important. So ICG today we will use for the clipping case, which already is opening. The ICG is a real-time evaluation, and also the monitoring is another very important thing. Sometimes it makes us very nervous, the monitoring. And also the fever, which I talked. So this is the patient has a two aneurysm, vaginal and also the anterocoidal. So this is the level. So how you can see the fever or ICG. So this is extradural anterocranial process plus the drills, and also posterior climbing as the resected, and you can get more space because this is the posterior fossa, so it's a very narrow space. So we can check all perforators, and the yellow cap aneurysm, small one, that is anterocoroidal. So this is now the liver is coming. So the deeper place is a little bit difficult to recognize, but the very shallow part is easy to understand. So usually the measurement, and some part is very thin, and the next area is rather thick. So we put a clip. Then after clip, then once again the deeper. And finally, just we can put the anterocoroidal aneurysm. I don't know why some part is such a yellow track and some part is very thin. It's very combining. So and also the microscope Flow 800, we can understand how fast of the reach of the flow, the red part, and blue part is a very delayed reach of the blood flow. So this is and also this is intensity analysis. Here is some small white part. This means it's incomplete occlusion. So we should replace of the aneurysm clip. So, and also the endoscope ICG. This is in the future. Still, it's not available. The real time, and also that we can check with endoscope the ICG detection. So because most of the deeper place is very quite difficult to check the ICG. So this is the conclusion. So I want to invite all of you because this is already next week. It's impossible maybe. So already next year. So I do the such kind of surgery course every year. And also once again the fellows ACNS in Dubai. Thank you for your attention.
Not have thrombus. In this chance, we can treat these capsules with intact and then see neck much more clear.
So it needs some break.